used to work on road for New South Wales Ambulance together. This was quite some time ago. And now you, from there, moved into nursing. And I think it would be great to start off with a bit of an explanation about your background and what it is that you do now in your role.
Thanks, Tara. Well, yeah, I was a New South Wales paramedic for 18 years, but in that time, I found that I started becoming known as the guy who was really good with mental health. So if we were to be going to a mental health job and I was driving, my partner would say, "Do you want to do this one?" So I think I have a natural affinity to mental health consumers. Even though I loved ambulance and stuff, in the end, I thought I just want to be around mental health consumers a bit more. And in that, so now I'm working as a clinical nurse educator at one of the major hospitals down here, on one of the acute mental health inpatient units. And yeah, I suppose I've got a lot of theories and stuff around mental health situations in ambulance. You're right.
So I think it would be useful maybe if you could describe a little bit about the inpatient unit. So basically, after we pick someone up in the ambulance, we take them into emergency, we hand over to triage, and then that patient gets admitted. Can you explain that process of what happens after that?
Yes. There's this saying that the path to hell was paved with good intentions. What actually happens, and it's one of my bugbears coming out of ambulance, where everything was really, well, things were a lot more pragmatic in ambulance. Once we get in the doors of the hospital system, I'm sure some of your students are already working there, everything is very much measured out around a level of risk. So the first thing when we admit somebody is a really big admission process of documentation, searching, using security metal detectors, searching the seams of people's clothing, and it can be quite intrusive to the person at times, but it has to sort of be that way. What happens, I think, is that we have such an exhaustive list of tasks that we start to neglect, or we run the risk of potentially neglecting the way that we do things, not so much as what we do, but the way in which we do them.
That's a very interesting point, because I think that same concept is something that occurs on road as well, in the situation that we get so many calls every day. We respond to so many cases. And I will say as well, Eddie, in the time that you've left, the amount of jobs that crews do each day is increased dramatically. So, you know, it used to be that we would get downtime during the day, during the night, but now crews are pretty much pumped the whole time. And the problem with that is the exhaustion that you get from the clinician. So when you attend cases like what you're talking about, that we do run the risk of forgetting what the most important part is there.
Yeah.
So I was going to say, what might be useful now is what do you think the most important parts, and what are the most important things to address in these situations?
Yeah, that's a great question. Look, I think the evidence is starting to mount now that if we focus on how the manner in which we do things, we're likely to get a better outcome. In fact, I remember one of my very first shifts working in Chinatown in Sydney, and I was rostered on with Paul Tonge, who's now a zone manager or something. And I remember Paul saying to me, "Mate, do you remember Protocol 1?" And I said, "Yeah, I remember Protocol 1. It's primum non nocere, that first do no harm." And he looked at me and he said, "No, not that. Protocol, not that. Protocol 1 in this ambulance, mate, is don't get punched." He goes, "So no matter what, do not get punched. So we're going to do everything we can to not get punched." And I think Paul was onto something there because when I watched him work, he was nothing but a gentleman with everybody, you know. And I think we can be a little bit judgmental in our society, and everybody's stressed out, and we can come with expectations to when we approach a person in any sort of scenario. But we've got to remember that there's a power imbalance in the engagement that we have, and like it or not, we are choosing to enter into that relationship. The person at the other end doesn't get a choice. Um, so there are some inherent things in which we communicate to people. It's, you know, a large part of our communication is the tone of voice that we use and our body language. And I think with mental health, we were talking before about how the diagnostic manual for mental health can be really, really in depth. And again, it's that path to hell paved with good intentions.
Yeah, yeah.
But ultimately, you could use as a strong rule of thumb that when we're going to a mental health job, there'll be some major narratives going on for the person. One of those narratives will be a rejection sensitivity, and the other will be an authority sensitivity. So we've got to remember and that's why in mental health nursing, we try not to wear uniforms anymore. We want to try and break down that power imbalance. And ultimately, going back to that rule number one of don't get punched, it's really, really important with my voice tone and my body language that I engage. My initial engagement is as respectful as I can possibly make it. I don't buy into the scenario of if I, as a young paramedic, if I look and act burnt out, I'll be accepted by the older people.
Yeah,
you know, because ultimately, this will be, and it's evidence-based now, that this will be the maximization of our chances of not getting punched.
Yeah, definitely. And when you talk about that, the experience that you had there, it actually echoed with me, and I could think of several clinicians that I would describe in that way, who are absolutely respectful to everyone, and the reputation that they have on road is impeccable. You know, as far as performance goes, as far as scene management, all of that kind of stuff, they just gets such a good reputation just from being able to build that rapport with anyone that they come across, because they treat everyone with an immense amount of respect.
Yeah.
It was interesting. I had a conversation the other day around some scenarios that we'd done, and we were talking about how to approach these situations, and someone mentioned the importance of that person's dignity. And when you're in a situation where you are caring and attending to someone who is generally, when they call an ambulance, at absolute crisis point, there's a lot of issues around dignity. What are your thoughts on that? Because, you know, like it can be a really difficult situation.
Yeah, absolutely. And that's part of the reason why there's a push for moving people away from being transported in a police car, then moving people away. You know, there's this thing I'm sure everybody's heard of called stigma in mental health. You know, and what vehicle a person is seen in the neighbourhood to walk out of their house and step into can create a big dynamic between what the neighbours think. You know, so the saying is, if the person goes in a police car, the neighbours worry about themselves. If the person goes in an ambulance, the neighbours might worry about the actual person.
Yeah.
So we don't want to ratchet up risk and stigma as if we can, as little as we can anyway.
Yeah. And I think and I was going to say, I think as well, really the bottom line is treating someone like they have a medical condition rather than treating them like they're a criminal, you know. And you and I witnessed, I'm sure, many situations over the years where people were treated with very little respect, and it saddens me to think back in about all of that kind of stuff and how poorly some people get treated.
Yeah, absolutely. And Tara, I'm sure, students listening to this would have even had their own experiences, whether it be in a shop or at school, or just that realization when somebody's going too far and it's not necessarily the best approach.
Mm.
We have this movement in the mental health service that it's called trauma informed care, and we're talking about psychological trauma now. But the 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 bottom, the underlying uh, state, the underlying philosophies in trauma informed care is to try to ingrain in my treatment when I'm engaging in a medical scenario, try to engage the idea that no human behavior comes from nothing. So if somebody's acting like a pork chop and it's not something that I would do,
Mm.
I've got to try and remind myself I didn't walk in their shoes every day
Mm.
of their life. And
Mm.
maybe I would be the same if I'd walked in their shoes.
Yeah.
So
Yeah.
so so the idea is that I ask myself, instead of saying what's wrong with this person, as we're taught to in ambulance and in nursing and medical field,
Mm.
ask myself what's happened to this person.
Yeah.
Why would this person be this way? Why would this person bang their head against the wall, cut their wrists,
Yeah.
threaten everybody, want to take on six police?
Mm.
Um, and once I can do that, I can. The idea is the flow on effect is my voice tone, my body language, everything I do. It might not always work. It might end up still being a case of the person is restrained and having to be sedated,
Yeah.
but
Yeah.
I can rest assured that I've done everything in my can to mitigate that.
Mm. Yeah.
Because we don't really work in a health system that recognizes and reports on successful de-escalation.
Yeah.
We recognize and report on negative things like
Yeah.
assaults and stuff like
Yeah.
that. So those things don't come up on the radar. So it's really about, for me, holding true to the ideal that I know the evidence is in that this stuff gets better results.
Yeah.
Doesn't always work, but it gets better
Yeah.
results than not engaging with it.
Yeah, I know from my experience, there's certain times when you need to be more aware of the possibility that de-escalation isn't going to work. And I
Mm,
suppose for me, when we're talking about behavioural stuff, is whenever someone's got drug and alcohol on board,
mhm.
any kind of drug and alcohol is going to make them less able to think in a rational manner, really. And I think that's the bottom line. Uh,
Yeah.
and I suppose I'd probably add to that, this is just from me, get your thoughts on that, is that possibly someone who is experiencing an acute psychosis.
Yeah,
Do you agree?
absolutely. Yeah, absolutely. Yeah,
Mm.
yeah. I mean, I remember working in George Street in Sydney for years with really, like you say, really experienced ambos that,
Mm.
I used to get triggered by certain things. I used to get
Yeah.
triggered by drunk people that wanted to put blood on me. They'd always want to touch me.
Yeah, nice.
Um, Yet these people, by being inherently respectful and gentlemanly or gentlewomanly,
Mm.
I always felt as though we got better results. We
Yeah,
didn't get
definitely.
assaulted ourselves. We didn't aggravate situations.
Yeah. I
Um,
yeah, I agree. I think that essentially it's just going to make everything run smoother, isn't it?
Absolutely, yeah, yeah, and that's what we all want. And I suppose the other thing about that is as well, we have to remember that we've got an obligation to our partner,
Yeah.
our ambulance partner. We've got an obligation to the hospital staff. Sure, we could ask the police to restrain somebody and
Mm.
drag them by the scruff of their shirt into the ED, but then we're going to leave them there, and that's not
Yeah.
really nice for our colleagues either.
Mm, mm. No, that's 100% right. What are your thoughts about uh, ED admission as opposed to admission directly toward a facility? How does that work in the area that you're in? I know there's some hospitals in Sydney that now do direct admissions. Is that occurring around your area as well?
Look, there's always a place for it. Again, there are very stringent rules and structures around the potential for an underlying organic cause.
Mm, mm,
So currently here, we would need almost virtual evidence that a recent medical clearance had been made.
Yeah.
But from the point of view of the consumer and the emergency department,
Yeah.
it would be absolutely, a first class way to go to avoid the emergency department.
Yeah, there is difficulties that I've encountered that I've heard from feedback from other people as well is particularly around if you're taking someone for a direct admission. And I've witnessed this a couple of times where you arrive at the facility and then you get knocked back. And I think for someone who's not in a good place, an experience like that can be really destructive towards how they're feeling at the time as well.
Yeah, absolutely. I mean, that's that and many other layers of bureaucracy impact the way that the consumer journey does go through. So are they being knocked back for a lack of medical clearance?
Various different reasons. It can be that. It can be lack of beds, lack of facilities, inadequate staff numbers, a whole bunch of different things that are not even related to the patient or the situation itself, but just more general crap that seems to kind of get in the way,
Yeah.
And
it's difficult, Tari, and another underlying thing of all this that's in the mix is, does the person even really need to be in an acute mental health unit? Apparently, we're admitting a lot of people in community mental health. It's about covering our own bums when it comes to risk, and there's a lot of movement now to try and give people what they call a dignity of risk. To be able to manage. We're also looking at some peer worker safe houses where people with lived experience of mental illness work, and we could possibly drop people that are in distress off there. Where the bureaucracy hasn't quite reached that sort of level of those sort of places yet. So there's actually there's a lot more therapeutic stuff going on.
Wow, that's really interesting.
Yeah.
I suppose the last question I'll ask you in regards to acute care, so to do with emergency and hospital admission, is I like to talk about the importance of just that initial encounter and how that can really have such an either positive or negative effect on that person's experience while they're in hospital. Can you talk me through that a little bit more? And how, from your position there, how do you see the paramedics that present patients to the hospital? Do you believe that things are being done correctly, or are there areas that possibly need to be improved?
Yeah, look, it's really hard. Paramedics have a very much are in a critical care acute mentality, and this is the other end of the spectrum. This is rather than the science, this is the art end of the spectrum, and how we hand people over. We can twist a subtle message in our handover to people. So right from the start, I think being as positive as we can about the person, trying to reflect on when I might be a bit disparaging. Because not for some social justice reason, not for some personal opinion, but for all the evidence that is mounting that this really is the best way to go about things. If rule number one is don't get punched, and safety needs to come first. So it's a hard gig for a paramedic to go from pragmatic, bang, 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 to okay, this job might take some time. But it takes the time that it takes.
Exactly.
And the worst thing I can do is try to rush it and push it, and then it all goes pear-shaped. So I think I try to consider an unconditional positive regard. Personally, I love it because it is all art, and whenever I see a new person, I really try to say to myself, look, inherently, we're all good. We are all good people, all of us. And I really want to try and appeal to this person to that good aspect. And that can pay off in spades. You know, that can pay off in satisfaction and a sense of a sense of work satisfaction where maybe in other cases somebody will go away with a truckload of frustration can actually be quite satisfying.
Yeah.
So,
I suppose the last question I'm going to ask you today is just a little bit about community care. Could you kind of outline to me what are some supports and what are some things that we offer within the community to assist people who are suffering from mental ill health?
Yeah, great question. And the answer is I don't know. No, not really. I do know, but what the answer is, it's becoming quite complex. That's why I say I don't know. We've had a rise in non-government organisations, service providers. If somebody is admitted to community mental health, they will have a care coordinator. Used to be called a care manager. But coordinating is really something essentially of what they're doing. It's going to be a little bit like triaging at a large car crash as a paramedic. It's about what services can this person be speared off to, what services hit certain things. So it's tricky. There are philosophies behind what we do as well. There's things called strengths-based care. There's things called flexible assertive treatment. But I don't want to go into those details too much.
It sounds very detailed.
It does sound very detailed. And then the other thing is as well that there's a private sector in psychiatry as well. There's a lot of private psychiatric hospitals, and sometimes there's certain types of people with a lot of trauma that I sort of tend to think do better in the private sector. Public system is very much about risk assessment and unfortunately, the thing that gives with that is therapeutic stuff. It's no one person's fault. It's just the way the system is.
And I think really when you're looking at individuals that are experiencing things, everyone's experience is so different, and what might work for one person may not work for someone else. Something else might work for them. Like there's so much variation there as far as effective treatment, really, isn't there?
Yeah. One other little bit of data for you, Tara. I can't quote the source specifically, but there's evidence now to say that when somebody in a healthcare role, or a police officer, or a transit police, or a security guard, or anybody is assaulted, there's something like a threefold chance that person has been assaulted previously in the last 2 years. That was a paper I was reading, a literature review. So I suppose for young people going into mental health, or new people, I shouldn't call people young, it's a factor to keep in mind, that there is some evidence that the variable in this stuff is how I am presenting myself, my voice tone, my body language, and my level of acceptance that this is actually part of my job. That can be a hard one for people to accept, and I understand that.
That's absolutely fascinating, and I think that's a really great note to end on.
Thanks, Tara.
Thank you for your time. It was great chatting with you.
Yeah, no worries. Pleasure.